du- during the course. So we can start without taking much time. I will introduce the speakers for the today's session. We have changed little bit of timetable without affecting the course. Today, speak on today our presenters are Dr. Hilary Fernando, consultant urological surgeon, teaching hospital Ratnapura. He's an eminent consultant urological surgeon, and also he has a lot of experience on palliative care. He will talk about managing issues of continence and stroma, followed by wound prevention course, prevention. Uh, the Dr. Tusita Kahadua will talk about wound prevention. So without taking much time, I would like to invite Dr. Hilary Fernando uh, to do the presentation. Over to you, Dr. Hilary.
Thank you, madam. Thank you very much, madam, for that kind introduction. I will be talking to you all on enteral nutrition, fecal and urinary diversion, and stomal care in the palliative setting. A little bit on palliative care. As you all know, it's an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, including physical, psychological, and spiritual problems. Now, there are uh, 8 domains of palliative care. And can you all hear me?
Yes, very well.
Yes, we can.
So there are 8 main domains of palliative care: the structure and process of care, physical aspects of care, psychological aspects, social aspects. So today my talk will be mainly on physical aspect of care. And there, the stomal care concentrates on gastric and biliary and bowel obstruction, urinary retention and incontinence management. So in surgical palliation, there are a few important concepts we need to adhere to, like maintaining general hygiene of the patient, skin care, oral care, things like that, maintaining the airway, then maintaining the nutrition of the patient, either by a mean of enteral nutrition, various tubes and stomas, and then evacuation of the bowel, bile, and urine, and then bed sore prevention and management. So maintaining nutrition is an important aspect in this regard. So there are 2 main modalities of nutrition: enteral and parenteral. Parenteral, of course, we use specifically in perioperative periods. In enteral nutrition is the nutritional modality we use generally in palliative setting. So people who cannot maintain the nutrition by taking meals orally, then the simplest form of enteral feeding is through the nasogastric feeding. That is a tube that we pass through the nose, nasal cavity, or through the esophagus, and we place it in the stomach. So that's called nasogastric. It could also be nasojejunal, and then PEG, percutaneous endoscopic gastrostomy feeding. This is an endoscopic guided application of a feeder tube into the stomach. And then feeding gastrostomies or jejunostomies that can be inserted in a mini laparotomy, and the tube or the catheter can be positioned under direct vision. And then endoscopic modalities are there to unobstruct the biliary system, that is endoscopic retrograde pancreatic sphincterotomies and biliary stenting. Those are there for malignancies involving the second part of the duodenum.
Excuse me, sir. Sorry to disturb you.
Yeah.
One of the participants have asked to, present it little louder because he can't hear, saying that it's on the chat.
Okay.
Yes,
Right.
sir.
Okay. Yeah. Okay. Can you hear me now?
Thank you very much, Dr. Hillary. Actually, we can hear very well. So may I kindly request all the participants to increase your volume. Right. You can
Yeah,
start.
I also heard very well now.
Yeah.
Yeah.
Can you please increase your volume? Then you will be able to hear very well. You can start.
Okay. So then the another modality is gastrojejunostomies. That is when there are obstructions in the normal anatomical pathway from the stomach, duodenum to small intestine. When there are obstructions in the normal anatomical pathway, you can make surgical stoma internally from the stomach to the small intestine. Those are called gastrojejunostomies. That bypasses the obstruction mainly in the duodenal region. Right. So this is a nasogastric feeding demonstrated here on a mannequin. And you all know how to take the measurement from the nose to tragus, from this area to the tragus, and then to the ciphisternum. And then when you insert it, you check with injecting some air and listening over the stomach to make sure the tube is positioned. And then you dip it in a saline to make sure whether the tube is bubbling. If that is the case, then it may be in the airway. So once you confirm, first you give some water and see. And then after that, you can give some liquid diet. And once you one second. Once you feed, the tube has to be flushed with saline or water to make sure the residual food particles are not retaining in the tube. Right. Then the percutaneous endoscopic gastrostomy feeding. This, of course, is a tube inserted by use of endoscopy to visualize from inside the stomach. And then you position it like this. And there is a small retention balloon there and another retention device staying outside the body like this. So this is a picture of open gastrostomy or open jejunostomy. There is a mini laparotomy here, and then you take the catheter through a separate skin stab incision, and then take it into either stomach or the jejunum, and make sure you apply a purse string and apply and get the stomach or the jejunum closely attached to the parietal peritoneum to make sure there is proper adhesion or sealing. And then you can start feeding with these liquid diets. So then those are the examples of maintaining enteral nutrition. And then comes the evacuation of the bowel. When there are obstructions, either mechanical or due to tumors or non-motile segments or due to invasion of various other malignancies. So we need to put stomas to evacuate the bowel. For example, if that is to evacuate the small intestine, we take ileostomies. And if it is to evacuate the large bowel, we call them colostomies. And then there is a special entity of entity called enterocutaneous fistula management. That is very challenging part of the of these out of all these. So these are the demonstration of types of stomas. So it could be a jejunostomy if the stoma is taken from the proximal small intestine, or a jejunostomy if we take that stoma from the jejunum, the ileum. So these stomas, they produce large volume of effluent, and they are rich in enzymes. So these stomas, we create them as pouts, so that pout makes sure the enzyme-rich effluent gets directly into the stoma bag, rather than getting into contact with the skin. In which case, it can give rise to maceration of the skin around the stoma, or dermatitis, which can be really irritating in the long term. So it could be the large bowel stomas could be transverse colostomy, or right colostomies, or the left colostomy. So we call them compartments. And so these are the ones I have told about. The spouts, these are created in either urostomies or in ileostomies or jejunostomies, when the enzyme-rich effluent is known to damage the skin close to the stoma. So there are two types of stomas. One is an end stoma or loop stoma. In stoma, there is only one limb of the intestine taken out from the skin, through the skin. So there is only one node. But in looped stomas, there is the active stoma that puts out all the bowel contents. And then there is another tiny hole, which is the mucus fistula. This is there because the loop stoma is easy to reverse. You can actually take a small incision through that, cut out the skin, and then make the bowel continuity from there and put the bowel back in. So the loop stomas are easy to be reversed, whereas end stomas are more challenging. Right, now this is an example of compartment stoma, like end stoma. And this is a urostomy, where we have taken out the bladder and connected the two ureters into a segment of ileum, and we have taken it out as a spouting end stoma, the right iliac fossa. Right? So this diverts the urine when the bladder needs to be taken out for cancers and various other indications. So this again is what I have been telling you all. This is a spouting stoma, and this is the mucus fistula. So this is the end stoma or a looped stoma, right? So one end is actually producing the bowel content out, actually diverting the bowel out. The other one is just putting out or producing mucus, which is called the mucus fistula. So there are various complications related to stoma. they could be either early or late. So the early complications, the hemorrhage at the site of the stoma, then the high output of the stoma, like when massive amounts of stomal output is there, the patient can go into electrolyte imbalances and dehydration. So you need to manage the high output accordingly. Then the stomal ischemia. The stomal ischemia is evident and very unfortunate event. We need to redo the stoma. That is the case. So you can see the color, pink color of the stoma is going to be from various dull, purplish, bluish, blackish. So those are the hues ischemic stoma would show. Then the stomal retraction. The stoma would go back into the tummy, and then obstruction secondary to adhesion formation. So those are the early ones. And then the late ones, obstruction, dermatitis, intussusception, prolapse of the stoma, parastomal hernias that is coming out parastomally. Then the stomal stenosis. This happens when there is long-standing ischemia or fistulae that connects the bowel through a different tract other than the controlled stoma we have created. And then psychological problems, and then failure of or need to reposition because of difficulty of bag placement and various other things. So these are a few images of what I have been telling you about. The dermatitis related to these high enzymes or the adhesive chemicals of the base plate of the stoma. And then this is a stomal fistula where there is another fistulous tract draining into the skin. Excuse me. And this is stomal retraction where the stoma actually tries to get into the tummy. And this is the stomal prolapse. This is not the spouting stoma I have told you about. This is actually a stomal prolapse. It's like a trunk of an elephant. Stomal ischemia, then the whole stoma looks black, right? So then the enterocutaneous fistula, this is a very troublesome form of a discharging sinuses, abnormal sinuses that discharge the bowel contents onto the skin. So there are various conditions like Crohn's, tuberculosis, radiation-induced injuries. Then these are evident in laparostomies where the abdominal closure is not easy, especially with abdominal compartment syndromes and all, where we need to apply laparostomy with various techniques to close the abdomen without increasing the intra-abdominal pressure. And then you can see on the first image here, the granulation tissue is there, but there are few places of abnormal connections into the intestinal lumen. The trouble with this is this discharge is continuously contaminating the wound surface here. So this is a way of managing it. Here, of course, the negative pressure wound therapy is applied with base plate applied to these this particular enterocutaneous fistula site. So this is what an enterocutaneous fistula is like. The intestinal lumen connects through an abnormal connection into the skin. So the high output, low output issues, the contamination of the wound are always there in these sort of the enterocutaneous fistulas. So when you are applying a ostomy bag, when do we advise our patients to empty the bag? So the ideal time would be to empty when the bag is about 1/3 full. When it is halfway, you're still good. But if it goes beyond this line, due to the weight of the bag, it can fall out. And those who know the mechanism of this attachment, there is a sealing device on this ring. And it can't bear that much of a weight. Sometimes there are straps that can fasten the bag onto the waistline or a line that helps to bear the weight. But when the bag is ideally 1/3 filled, that is the time to ideally empty, or maybe when it is half, not beyond that. Right? Now, then comes the diversion of urine. Why are we talking about all these things? Because when there is the wound healing process is can be affected by contamination with the bowel contents or the urine. So the reason why we discuss this is to teach you all about how to control these fistulous openings or the stomas so that it won't contaminate the wounds for optimal wound healing purposes. As you all know, these effluents contain lots of bacteria and various irritants, enzymes that can hinder the wound healing process. So once this is controlled and drained in a controlled fashion, rest of the wound heals very easily, preventing any contamination of the general wound. So the diversion of the urine could be either from the upper tract. The upper urinary tract means the ureters or the kidneys. So it could be percutaneous nephrostomies. It could be by means of pigtail catheters, or those are temporary ones, or the permanent catheters like insertion of a catheter that can be changed in the mode. Even a PCN, percutaneous nephrostomy, can be changed once the tract has matured, say about 4 to 6 weeks later. Once the tract is matured, it can be safely repositioned in the ward setting even. Then the stents, that's an internal way of, can be normal stents or reinforced stents. The reinforced stents have metallic coils incorporated into the stent plastic, or metallic ones. They are used in malignant ureteric obstructions. Or then comes the surgical diversion of the upper tract. Yeah, I have shown you urinary diversion by means of ileal conduit. So the same concept can be utilized when there is a stoma, like a colostomy. And if you're not going to use that stoma for anything else, that colonic stoma could also be a good conduit for the urostoma. So it could be a urostoma. So commonly we use ileal conduits, or sometimes when there is a colonic conduit which can be utilized without creating a new one, that could also be used as a diversion stoma for urine. So then the lower tract obstructions, suprapubic catheters, then indwelling catheters that are going to stay in the bladder for a long time. The general latex, siliconized latex catheters, we keep in the bladder for about 4 weeks. And then the 100% silicone catheters, you can keep inside, leave inside up to about 3 months. So those are the indwelling versions of the catheters. There is another version called continuous clean intermittent self-catheterization, especially when there are neuropathic reasons and the bladder cannot be emptied. If the patient has good vision and hand function, then they can apply this clean intermittent self-catheterization to drain their bladders. Then there is a concept called condom catheters. So the condom catheters, actually drain the urine when the patient is incontinent. When the patient is completely incontinent, the condom catheters collect the urine that is seeping out of the penis. Then the other one, the surgical one, is various types of neobladders. So it could be orthotopic, meaning you take out the bladder and you create the neobladder in the place of the original bladder and try to utilize the normal urethra as the outflow tract. Or it could be heterotropic, like the bladder could be opening onto the abdominal wall by means of metrophin of urinary diversion. That is, use of either appendix or a tubularized ileum to connect the neobladder onto the skin. So this is how acute urinary retention would look like from the side. You can see the contour of the bladder distending the lower abdomen. And so if you can't pass, the ideal way to decompress, now this is a very painful condition. The way to relieve the pain is to put a catheter, indwelling catheter in. If you can't put a catheter, either due to a stricture or a iatrogenic injury that has given rise to a false tract, then the next option would be to drain the bladder to reduce the pain. That is, to reduce the bladder distension and to reduce the pain by aspiration suprapubically. You can do this either by a large bore cannula, either orange or gray cannula, into the bladder and connecting a saline tube and draining, allowing it to drain out to a lower position. So then that way you can buy some time until the patient is transferred to a surgical unit where they can put a suprapubic catheter. So this is the indwelling catheter, or this is the suprapubic catheter. So this is a suprapubic catheter set. So when you're inserting a catheter, make sure you have all the amenities available, like make sure the sheath accommodates the catheter well. I mean, if the sheath cannot accommodate the catheter you have, you cannot use that suprapubic puncture kit. And then the bladder, the distilled water has to be drawn and be ready to inflate the balloon as soon as the trocar and this introducer gets into the bladder. And make sure the bladder is full and palpable and percussible above the pubic symphysis. If the bladder is not palpable, this is not an ideal way. Especially if the patient has had any laparotomies or lower abdominal surgeries, bowel loops can be in the vicinity of the suprapubic tract. So you need to be very vigilant on putting a suprapubic catheter in a patient with these sort of lower abdominal operations. So this is a percutaneous.
Yes, sir. Basically, only when there's a distension that you can try for a suprapubic catheter, isn't it?
Yes. Otherwise, you need to distend the bladder by ultrasonically identifying the bladder and putting a cannula, and then you can put a saline in and make sure the bladder is full, because otherwise it can go into various other places other than the bladder. It can give rise to polovisceral fistulas, which is one of the horrid complications of this percutaneous nephrostomy. Patients can actually die out of those. So make sure the bladder is full and palpable above the pubic symphysis before you attempt a suprapubic catheter. Right?
Thank you very much, sir.
This is demonstration of a percutaneous nephrostomy, where we have put a pigtail catheter, positioned the pigtail catheter into the pericardial system to divert the urine from the kidney itself. So that urine won't reach the bladder, right? So when there are malignancies in the uterine cervix or prostate cancers that have grown beyond the bladder and the distal ureters, we can't possibly put retrograde stents. Even if you put retrograde stents, the stent gets obstructed very soon. So the patient will be in and out of the hospital throughout. So the percutaneous nephrostomy would be the ideal option draining such kind of patients. So this is the commonly radiologically positioned percutaneous nephrostomy to divert the urine from the kidney itself. And surgically, you can put a Foley catheter into the pericardial system. And that catheter can be changed in the ward setting once the tract is mature. This can also be done at the ward setting once the tract is matured, maybe 4 to 6 weeks later. But if you dislodge or the catheter gets out of the pericardial system, then the whole procedure has to be redone under image guidance at the radiological interventional radiology setting. So this is the condom catheter I have discussed earlier. That drains all the urine that is drained out of the penis. Now this is useful when the continence mechanism is gone in a patient, maybe due to prostate cancer, maybe bladder cancer, or the radiation-induced issues. Then this is very handy way of preventing contamination or contamination of bed sores with urine. You can use this. The other way is to use a diaper, but then the diaper, the whole thing gets absorbed and can contaminate the bed sores, especially the bed sores in the sacral area and all. They tend to get contaminated with these. Now, the bed sores or deep wounds in the perineum or colovesical fistulas, rectovesical fistulas, due to radiation and then some surgical insult later, they can give rise to rectovesical or rectourethral, or they can give rise to various other sorts of fistulas. Or the fecal stream or urine stream can contaminate the wounds. So when that is there, to help wound healing process, we need to divert the urinary and the fecal streams away from the wound site to facilitate wound healing. So these techniques I have told you are very important to facilitate proper wound healing by means of diverting fecal and urinary streams away from the wound site. So my talk is basically on those aspects to give you an idea when we surgically divert fecal and urinary streams to help a wound healing process surgically, especially in palliative settings. Any questions I would like to answer now? Is everything very clear to you, or are there any questions you need to ask?
Are you
No,
participants? Can you please ask questions from this chapter? Over to you.
So I'm Pranit from Horana.
Yeah.
So with regard to removal of a catheter,
Yes.
during our medical training, we learned about preparing the bladder for the for the dead Crusoe muscle to train the normal process after removal. So is there any new concepts regarding removal of catheter?
Now, most of the medical units, of course, even to date, I have seen they check the bladder sensation before removal. This is useful, especially when you suspect long-term chronic obstructive causes or neuropathic causes. Then the chances of failure of trial without catheter is high when the patient cannot feel whether the bladder is full or not. But commonly, this happens in acute urinary retentions, where it could be a spontaneous one or induced one, or like provoked one. Provoked one is when the patients undergo surgery in the pelvic region, perineum, hemorrhoidectomy, hernias. So those are provoked acute retentions, or spontaneous ones, especially with infections, when there is preceding nuts and ultimately terminating in inability to pass urine. Those patients, you can actually take the catheter out without checking for bladder sensation, because they are the process is intact, mechanism is intact. This is important in chronic retentions and neuropathic bladders, where the patients can't actually feel the bladder. Now, when you are changing the catheter, it has to be done with aseptic techniques, and you can clamp the catheter for a little while before you actually change. In that way, once the new catheter goes in, you can appreciate the urine coming out of the new catheter. Otherwise, you don't know whether the new catheter has reached the bladder or not. So when you are changing the suprapubic catheter, again, aseptic condition, you can put a half a bottle of saline into the catheter to distend the bladder. And once you put the catheter back in, you can immediately appreciate the saline coming into the new suprapubic catheter. So those are a few important practical aspects of changing catheters and changing suprapubic catheters. And especially suprapubic catheters, make note of what is the size of the catheter the patient is on. For example, now there is a color code. Green is 14, right? Orange is 16. Likewise, there is a color code, right? 18 is red, yellow is 20, 22 is purple, 24 is blue. So, so there is a color code. So make note of what sort of catheter the patient is wearing. So have the exact same size with you before you attempt change. Because if you put a smaller catheter, then there can be leaking around the catheter. If it is too large, then you might find it difficult to put it through the tract that is small. So those are a few important practical aspects. Did that answer your question, Praneeth?
Yes, sir. Thank you very much. Another one, as you said, sir, if there is any leaking catheter, do we have to go up the gauge? Like, for example, we are using, for example, a 14 gauge. Is it okay to go up to 16? Like,
yeah. Again, a good question. Now, in females, we advocate the catheter to be small, maybe 14. In males, 16. Those are the standard catheter sizes we used in males and females. Now, when there is a leak, it could be due to two main reasons. One is the catheter is too small, or there can be bladder spasm. So this concept of bladder spasm is when there is a painful contraction of the detrusor muscle. So however big catheter you put, sometimes if the patients can live. So if that is the case, you need to put a bladder paralyzing agent like oxybutynin, tolterodine, or solifenacine to paralyze the bladder in some of these patients. So the reason why we ask female catheter to be 14 and male catheter to be 16 is the urethra is not just a passive tube. It has urethral gland opening onto the urethra. So once there is a bigger catheter and blocks these urethral glands, it can give rise to infection of these urethral glands and give rise to a stricture formation. So that's how the STDs and urethritis gives rise to strictures, infection of these urethral glands. So if you put bigger catheter, so there is a risk of inducing a long-term stricture. So in the history, ask whether the patient has some suprapubic pain and maybe aching type of pain just before this particular leak. If that is the case of a bladder spasm. Then however big a catheter you put in, it's not going to help. So then the treatment of choice would be to put something like solifenacine, like Solpicam, Daditone, or something like that to help paralyze the bladder. And sometimes you can adjust the balloon volume. You can titrate up and down and see whether you can get the catheter seated on the bladder neck well to see whether that can potentially help prevent the cancer. There is no one way of doing it. So it depends on what sort of symptoms the patient is having. This concept of bladder spasm is something that is often overlooked by other guys.
Any more questions?
Thank you very much, sir.
Okay.
Sir. Sir.
Yeah.
Sir.
Yes.
Sir, with the UTI, can we get leaking of the bladder catheters?
Yes, you can. Especially when there are UTIs, there can be sludge in the bladder that momentarily blocks the catheter lumen. If that is the case, once the bladder pressure increases, there is a paracatheter leak. And it's an inflammatory condition that gives rise to detrusor instability and overactive sort of bladder. That's why you get difficult to hold urine and urgency, that is the difficulty to differ going to empty the bladder. You can't hold urine. That's called urgency. When there is urinary leak related to urgency, we call it urgency urinary incontinence. So those are there in UTI, especially because of the bladder overactivity. Because of the detrusor overactivity caused by the inflammation by these infections. So UTI is actually infection of the urothelium. So once the urothelium is infected, the other layers, the lamina propria, musculus propria, can also get inflamed and give rise to bladder spasms and overactive features that are common to urinary tract infections. The other thing is sludge. The whitish, milky sort of thick sludge sometimes blocks the catheter. Sometimes that is an indication for us to give a bladder wash. If it is a two-way catheter, we sometimes put half a normal saline in and allow it to drain, especially if the patient is not producing urine. So we give through a two-way polycatheter, you can instill about 250 saline in the morning and let it out shortly after that. Likewise, you can give bladder washes maybe 2 times, 3 times to get rid of this sludge. Or otherwise, you can put a three-way catheter to irrigate the bladder to get rid of this sludge. That's another way of doing it. Now, this is applicable also to like bladder tumor resections and TURBs and all when there there is a tendency to bleed and clot formation in the bladder, then the catheter lumen can get blocked and the urine and the blood tends to come around the catheter. That is because of the clot retention and blockade of the catheter. Then the bladder luminal contents get to the exterior around the catheter. Right? That's an indication of catheter block. So in UTIs, that is very common as well.
Any other questions?
Yeah, I have my own two questions to Hilary. One is that in say in palliative care patients with long-term indwelling catheters, you get this whitish gooey thing inside that is most probably the yeast. So that is very annoying to watch for the bystanders, so the caretakers. So they get annoyed of this whitish stuff is growing even if you put the catheter last week. So is there any way to reduce the formation or delay the formation of that biofilm sort of thing?
When the patients are on long-standing antibiotics, and there are various immunosuppressive conditions and chronic catheter patients, it's inevitably they get these fungal infections. But so the prevention of general urinary tract infections in long-term catheter patients, I would say like not to put the catheter on the floor. And they can wear the catheter either on the thigh or on the calf, not allowing this to be getting into contact with the floor. If they go to a toilet, they can put the catheter and the tubing on a clean bucket, plastic bucket or something, which is routinely cleaned with some disinfectant, maybe hand wash or something like that, that gets rid of most of the bacterial infections there and can keep it there if they go to a toilet. Another way to reduce the infection of these infections are actually ascending infections. So you can prevent the distal tip or the valve or the bag gets infected before, and then it ascends through the tubing into the catheter. So if you change the urine bag every 2 weeks, that's another way to reduce the colonization. Because by 4 weeks, the whole catheter is colonized. And now we know the bladder is not sterile. Even though it was thought to be sterile, the bladder has its own microbiome inside. So there are bugs which are cohabiting in the bladder, and they are the good ones. Once this harmony is broken by colonization with other guys, then there is infection and sludge formation, then the yeast formation, various things. So the bladder washers, keeping them well hydrated to now the one main innate defense mechanisms in the urinary tract is a flow of urine. So often these patients don't drink much or they are dehydrated. So there is no proper urinary stream within the system. So the thing gets infected. So if you keep them hydrated, another way to prevent these infections. And then usually the pH changes. The natural lemonades or whatever we call like narang, or any sort of citrus, they have potassium citrate in them. So that's a urinary buffer, which is very inexpensive and you can use in these patients. And we use them in various other medications like potassium citrates that's coming in various formularies like potassium citrate, high strength tablets, various combinations of therapy we use to prevent these infections. But these homemade lemonade like stuff also helps to maintain the urinary pH within the optimal range to prevent infections. So there is no one particular way, but there are multitude of ways and means you can utilize to prevent these infections.
So excuse me.
To
So in which, in which ways we can use lemonade as a juice? So is there any particular way that we can ask them to use lemonade and citrus fruits?
Like a juice?
Okay.
Right? Yeah, but like you can squeeze the lemon and put a little bit of so it has to be a little appetizing as well, no?
Yeah. No, I have heard that we have to put some pieces all night in the water, and then in the morning we have to ask them to drink. So just want to clarify.
Yeah, there are various, those are not actually Western medical practices as such. What I'm telling is Western practices that we can use these normal food items, which are rich in potassium citrate and stuff, to create these stuff in very inexpensive ways.
Okay, there's another question that I wanted to ask. Actually, now with patients with long-term indwelling catheters, there's a chance of getting the balloon blocked. What should we do if the balloon is blocked and you cannot take out the filled water, and basically you cannot do the dressing change in the OPD setting?
Yeah. So there are different ways to rupture the balloon. One is to do the radiologically guided puncture of the balloon. That is, you under ultrasound vision, you pass a catheter through the tummy, and then you rupture the balloon. That's a common way of doing it. And then in females, the urethra is short, and then sometimes you can actually, when you pull on the catheter, you can see the neck of the catheter balloon, and then you can rupture without much effort. Then from urological point of view, we can put tiny instruments through the urethra parallel to the catheter, and put either sharp wire or laser fiber or something like that to make a small puncture hole into the balloon. So there are various things that we do, so one important aspect, the important thing is not to cut the valve if it is difficult, because if you are planning to get radiological support, it is difficult to inflate the balloon for them to rupture if you cut the valve. So leave it to some surgical expert to do that. Sometimes if you cut close to the catheter, there is a water channel that is obvious on the catheter. Right? When you make a small incision on that, sometimes the block is more distal to the point where you make the cut, then you can deflate the balloon. The risk of doing that is if you fail in doing that, then you can't inflate the balloon a bit more for the ultrasound guided rupture of the balloon. Another issue is when the patients have long-term catheter patients, they have something called purple urine bag syndrome. That's an infection. The whole bag and the tubing turns purple. So there is an active infection there. So when there is an active infection, especially in long-term ill palliative patient or immunosuppressed patient, if you introduce that infection to the bloodstream by means of a puncture, then it can be very detrimental. It can give rise to ascending sepsis. So in such patients, we sometimes put tiny instruments parallel to the catheter without traumatizing. We put a small hole in the balloon and take the catheter out. So that's the urological procedure, if that is the case. Right? So there are various ways. The easiest way for general purpose is to puncture it under radiological guidance using a needle.
Thank you, Hilary. There's a question in the chat. Is there a place for vitamin C in UTI treatment?
There is, especially when you treat UTIs with nitrofurantoin, we prescribe vitamin C with nitrofurantoin. That is to help complete the action of that. Now, nitrofurantoin is a bacteriostatic sort of antibiotic. It's more antiseptic. There is no proper tissue level, minimum inhibitory concentration, minimal bactericidal concentration. There are various concepts in these antibiotic management. So, nitrofurantoin is actually urinary antiseptic. Doesn't reach a proper tissue level as such. Now, UTI is actually infection that is there in the urothelium. So, that's so we use those combination to help get rid of these infections when we use nitrofurantoin. Now, the other question is place for cranberry and fructose supplements in UTIs. Now, I think there are various commercial forms. Utinome. Utinome is cranberry 200 milligram and D-mannose. That's the combination in utinome. And then cran DPC that has now cran D has cranberry and D-mannose combination. Then cran DPC has also the potassium citrate incorporated into those. So there are 3 combinations. Now, the D-mannose is known to block the binding sites of E. coli onto the urothelial cell. That's the idea of how it is prevented. Now, the cranberry is some sort of Western home remedies for UTIs. Now, that's something that they have been using over the years to get rid of burning sensation related to urination and make so cranberry substrates are sort of a plant-based derivative. Like in our Ayurveda, this is something used in the Western countries, plant-based sort of thing. Now, the fructose supplement you're referring is the D-mannose. D-mannose is known to block the binding sites of the flagella of into attaching them, preventing attaching them these E. coli to the urothelium. Then the potassium citrate, the same thing, like it is a urinary buffer. So if there are like changes in acid-base balance, you can change that to, for example, this Proteus species, they like alkaline urine. Then by changing it to more acidic urine, it can inhibit these Proteus. So various organisms are there. So UTI, Serratia, and various are so the commonest form would be E. coli and coliform. That's the 90% of the urinary tract infections.
Any more questions? Hello, any more questions you want to clarify from that section?
And a recurrent urinary tract infection is a problem that has to be dealt with a urologist at some point. So that's a good take-home message. So if you can't potentially treat at your setting, maybe better to get that patient referred to a urologist to get this sorted. I hope you all learned something about these urinary and fecal diversions out of today's talk.
Thank you very much, Dr. Hilary Fernando. Thank you so much for giving a very fruitful discussion. Thank you so much. Finally, I want to ask again, if you have any more questions, you can ask from him because he's very busy and sometime he will log out from the Zoom before starting the next session. Okay, thank you, Dr. Hilary. Thank you so much.
Okay.
So now we can start the next session. So we are going to do the session on wound prevention. So actually, especially the Dr. Dr. Tusitha Kahadua, already I have introduced. He is the course coordinator for this course, as well as he's a palliative care wound care practitioner. He will talk about how you are going to do the wound prevention at community primary care setting. Over to you, Dr. Tusitha.
Thank you, madam.
Tusitha, can you please put the screen mode?
Yeah, can't you all see it? I have shared.
We can see.
Yeah, that's the problem.
Yeah. Thank you.
Now,
All right. Perfect. Right. Okay.
so I mean, first of all, I should thank Hillary for agreeing just about 5 hours back to change his lecture to today during his busy schedule. So I mean, okay, there was a sudden change due to some meetings being held for university lecturers. So anyway, so let's without further ado, let's get down to business. So this was planned for the last session, but there's no it's not wrong to discuss prevention early. I mean, prevention should be first. So let's dive into it. So yes, prevention is actually you can even take it this way, to prevent any further complications from a something hanging from your back. You can sleep on your stomach. That sort of a prevention can also be done. So that's not what we are going to talk about today. So basically, if you dive into this, what we should always incorporate preventive measures, preventive aspects in our day-to-day management of wounds. That should include primary prevention, primordial prevention, primary, secondary, and tertiary, all 4 stages of prevention. And say if you talk about primordial prevention, that is basically if you talk about foot wounds, it's to prevent diabetes. And if you talk about talking about preventing bed sores, is to prevent the particular diseases that will make you get into a sort of a vegetable state. So that's the idea of primordial prevention. So prevention specialists are there. The presidents can correct me if I'm wrong. Am I correct, madam? Okay, so anyway, so you should always talk about healthy food habits, exercise, how to maintain a high activity level in their lives. Just ask whether what they are doing. They ask whether you can do some a little bit of exercise. There are seating exercise, all those tactics are there nowadays, and it's always already available in YouTube and all. So just ask them whether they can incorporate such things to get the activity level a little bit high. So advocate on correct weight height ratios, all that, and advocate on alcohol and tobacco. Reduction no avoidance of alcohol. So these are general conversation topics. While you are attending the vote, you can do this presentation. Not even or not only to the bystanders, onlookers and everybody.